I hope I'm clear. Just let me know if I'm audible and we'll begin. Sorry for the delay. There's some network issues here. Is it clear? Okay, fine. We'll begin. Okay, so first thing is we'll discuss how to approach LFT, the first part, and the second part I'll discuss how do we approach a thyroid function test. This is going to be very brief, and because LFT is very common, and a very commonly ordered test, and very common in clinical practice to notice some abnormality in the LFT, and you may not really be sure what is really happening to the patient. Okay, so first question is, the term LFT, does it really give the normal functions of the liver? That is the first question we ask ourselves. So then when we see that it is not equal to the liver function, so that is why the term LFT, it is more of a semantics rather than an actual term. So it's better to use liver chemistry rather than a liver function test. So that would be a more appropriate terminology for this. So what are the things we notice in the normal LFT? In the normal LFT, we can divide it into enzymes and mainly bilirubin handling and the synthetic functions of the liver. So what are the determinants that we have for each of this? In the enzymes, we are going to have AST and the ALT along with the ALP and GGT. These are the common enzymes that are done. Apart from that, we are going to get bilirubin handling. So mainly we look at the total bilirubin as well as the direct bilirubin. From that we derive the indirect bilirubin or the unconjugated bilirubin. Synthetic functions, mainly it produces the proteins, especially vitamin K dependent clotting factors as well. So in protein, we look at the albumin levels, the globulin levels, and PTINR, which represents the vitamin K dependent clotting factors. So these are the things that we have whenever we are looking at the liver. Apart from that, in the metabolism, we also have cholesterol. It's also involved in the cholesterol biosynthesis pathway. Apart from that, in the metabolism of the liver, the metabolic functions of the liver are many. One is the detoxification of the waste products. So what we call as xenobiotics. We have the phase 1, phase 2 reactions. Apart from that, it is involved in gluconeogenesis, glycolysis. So basically the glucose amino acid metabolism. It's also involved in the lipid metabolism. These are the other things. Apart from that, in the excretion, it is involved in handling of the bilirubin, mainly. Apart from that, ammonia detoxification comes here as well. In the synthetic functions of the liver, we have formation of plasma proteins along with that vitamin K dependent clotting factors. Apart from that, it also produces bile salts and bile acids. So these are the main functions that the liver has. So whenever we are looking at the liver function test per se, so are we really getting all of these functions? Only if a part of it we are going to get. So what are the main things that we are going to see whenever we are seeing a liver function test? The routine liver function tests, we can group them into enzymes, which mainly we can talk about AST and ALT. And we can divide it into a cholestatic enzyme pattern, which is marker of cholestasis, which are ALP and GGT. We'll come to each of these enzymes and their functioning in a very short while. Then we look at the bilirubin handling, whether it is conjugated, unconjugated. Then we look at the synthetic function. So the only things we have are the PTINR and the albumin. So coming to enzymes, we'll discuss few points about the enzymes. In the enzymes, so we have SGOT and SGPT, which are currently AST and ALT. So what are the function of this enzyme? It is involved in the transamination reaction in the liver. Transamination inside the liver. Outside the liver in the blood, what is its function? There is no really any function. Then we should know what are the normal levels, because beyond which we can call it abnormal. So how do you call it as a normal liver or normal enzyme levels? So we can take the upper limit of cutoff as 40. But even this is a debatable thing, because if you take the American guidelines, they say a different cutoff for both AST and ALT. So this is the cutoff for ALT and this is the cutoff for AST. The European guidelines are different, Korean guidelines are different. But in general, we take the upper limit as 40. So anything beyond that becomes significant. So coming to a single enzyme, which is ALT, L equals liver. So this is very specific for liver injury. More specific for injury compared to the AST. So what are the importance of ALT is? The half-life. So the half-life of this is somewhere about 47 hours. There can be non-hepatic sources, which is very, very minimal. So sometimes it can be in the RBCs, but more often and commonly you don't get those in the liver disease. So after ALT, we'll see AST. So AST is something interesting. So AST has two forms. One is the cytoplasmic form, which is circulating in the cytoplasm, and one is the mitochondrial variant, mitochondrial form, which is there inside the mitochondria. This is not circulating. The importance of this is majority of it is going to be mitochondrial, and about 20 to 30% is going to be cytoplasmic. And this is the thing that is going to be in circulation. The half-life of each of this is different. So the cytoplasmic AST and the mitochondrial AST have a different half-life. For this, it is going to be 17 hours. For this, it is going to be 87 hours. So how does knowing this help? I'll come to it. Whenever you have a mitochondrial injury, so you can still have the mitochondrial AST being high, and it can be more in the circulation. So this gets cleared off faster, cleared off by the reticuloendothelial system faster compared to the ALT. So how is it going to help me make decisions whenever I'm going to have elevation in the AST levels? So we'll see the pattern. So whenever I have an elevation in any of the enzymes, we can divide them into, whenever there is an injury, you can divide them into two patterns. One is a cholestatic pattern. How do you define hepatocellular pattern is? We look at the AST and ALT levels. It should be raised more than 3 times the upper limit of normal. Along with ALP and GGT should be less than 2 times upper limit of normal. This is how we define a hepatocellular pattern. So the cholestatic pattern, it's exactly the opposite. So the ALP and GGT is going to be elevated more than 3 times upper limit of normal. And the ALP, the AST and the ALT levels are going to be less than 2 times upper limit of normal. So when you have predominant ALP GGT elevation, it is cholestatic. AST ALT, it is going to be hepatocellular. The moment we say it is hepatocellular, so we have to see what is the clue that we are going to get whenever we have a hepatocellular pattern. For this, it depends on 3 things. One is you have to look at the extent of elevation. This is going to give a very important clue. Excuse me. So we'll see AST. In AST, one more thing we have to remember is what are the non-hepatic sources. So one is in the heart, one is in the brain, one is in the kidney, one is in the RBC. So these are the sources where you get AST also. So you can get an elevation of AST moderate. So it is greater than 5 times upper limit of normal. So you can get it in hepatic conditions, mainly inflammation. So it is very non-specific. It's going to be very non-specific and it will not give us any clue to the cause of why it is going to be elevated. But the important thing is not misdiagnosis. One here is alcoholic hepatitis. In alcoholic hepatitis, can you tell what happens to the AST and ALT? Any ratio you know? What happens to AST and ALT levels? It's not audible. It's audible, no? Yeah. Okay. So in alcoholic hepatitis, the importance is the AST and ALT levels. So the AST to ALT is greater than 2:1. This is very important and not to miss diagnosis. But not always AST is to ALT more than 2:1 means alcoholic hepatitis. You can also have other causes. But there are many reasons they state why you are going to get a AST by ALT more than 2:1. So one thing is to remember there are 3 reasons that they are stated. One reason is the ALT enzyme requires a cofactor called pyridoxine to form pyridoxal phosphate. So this is going to be reduced whenever patient consumes alcohol or ethanol. So whenever you have a low pyridoxal phosphate, you cannot form ALT. So once you can't form ALT, you're going to get low amounts of ALT. The other reason that is stated is ethanol can directly injure the mitochondria and cause release of the mitochondrial AST. So because of this, there is going to be a half-life. This is having 87 hours. So this is going to be persisting for longer time compared to the ALT, which has a half-life of 47 hours. The other thing that is stated is there is going to be a reduced clearance of AST. So these are the three reasons why the AST and ALT is more than 2:1. But most important is you should never diagnose alcoholic hepatitis. Never diagnose alcoholic hepatitis if the AST is greater than 500 or the ALT is greater than 300. So reason is because there are multiple reasons for this as well. We'll not go into all of the reason, but the proposed mechanism is ethanol is going to get converted into acetaldehyde. This acetaldehyde is going to directly inhibit these formations, the AST and ALT formation. So because of this, you are not going to expect a very high amount of AST and ALT. So that's why you should be very careful whenever you call it alcoholic hepatitis. So the AST is more than 500 and ALT more than 300. You don't call it alcoholic hepatitis. Look for other causes. The other place where you can use AST by ALT ratio, there are two things. One is you can have drug-mediated injuries, like statin-mediated. So there are multiple reasons why you can get an injury. So in that condition also, you can get AST more than ALT. One more not to miss condition is fulminant Wilson's. What do you mean by fulminant Wilson's is a patient with Wilson's disease presenting with acute liver failure. We call acute liver failure if the patient develops encephalopathy and coagulopathy within 26 weeks of the insult. So this is ALF. So whenever you have Wilson's disease presenting as an acute liver failure, because acute liver failure has multiple reasons. So in this condition, they have found two things that are very useful. One is the AST by ALT ratio more than 2.2, along with an alkaline phosphatase by total bilirubin level less than 4. If both are there, the specificity is 100% to diagnose Wilson's, to fulminant Wilson's. So this is another useful tool. Other thing is to differentiate. It helps in differentiating intrahepatic versus extrahepatic cholestasis. We'll come to this point as well. So these are the things that are commonly seen. So everyone thinks one is the alcoholic hepatitis, but most important is drugs. We see very common in the setting of COVID. There are multiple antibiotics, multiple things that are given that can cause elevation in the enzymes. And one more is Wilson's disease, and other is to help in differentiating intrahepatic versus extrahepatic cholestasis. The other extent of rise is more than 50 times upper limit of normal. Usually you will have in thousands. So this is one of the common things that they ask whenever you get AST and ALT in thousands. So there are very few differential diagnoses here, and this is one thing that should never be missed. So the first thing is acute hepatitis. Most commonly it is going to be viral. Acute viral hepatitis, either Hep B, Hep C, Hep A and Hep P. You also have other viruses like CMVBV, but they cause more of a cholestatic pattern rather than a hepatocellular pattern. Other not-term differential diagnosis is toxins. Very, very common toxins. Most commonly we see in clinical practice is paracetamol poisoning. So paracetamol poisoning, very few words I'll tell. So the toxic dose is more than 4 grams per day. So it can be in 2 doses. So it can be a single massive consumption, or it can be in a staggered form, like multiple small consumptions. So whenever the patient comes, so usually initial 24 hours patient will be asymptomatic. Next 40 to 72 hours is the important time when the patient starts developing GI symptoms. The patient can go into ALF, where the patient can develop coagulopathy. Multiple things, there can be cerebral edema, multiple things that can happen to the patient. But what is important is, for the sake of entrance, there are 2 things don't very commonly followed. So the timing at which the patient presents, time of presentation. So from the onset, if the patient is going to come after 4 hours, then you can use something called as a Rumac-Matthew nomogram. It's called as a nomogram. So Rumac-Matthew nomogram. It's called as a Rumac-Matthew nomogram. So this helps us in determining whether to give paracetamol or not. To give N-acetylcysteine, which is going to be the antidote. So the time taken here is, the cutoff is 4 hours. So after 4 hours, you send for the serum levels of acetaminophen or paracetamol. If it is going to be above this line, this is time in the x-axis, and the serum levels of acetaminophen in the y-axis. So if it is above, then you treat with N-acetylcysteine. If it is below, then you don't treat. But the most important thing to remember whenever you're using this nomogram is, it is going to be applicable only if it is going to be a single dose consumption. And the other thing to remember with this is, if the patient presents before 4 hours and still it's a toxic dose, you can go ahead and still give N-acetylcysteine, because the benefits far outweigh any risk that the patient can have. So loading for N-acetylcysteine is very simple. Remember 150, 50 and 100. This is going to be mg per kg. So if the patient is somewhere at 60 kg, you give somewhere at 900. So you divide it. So this is mg per kg, and there is a duration as well, in how long this has to be given. So the initial 150 mg per kg to be given within 30 to 1 hour, 30 minutes to 1 hour. The next 50 mg per kg has to be given over 4 hours. And this has to be given over 16 hours. What is the IV fluid used? It is given in 5% dextrose, 250 ml, 500 ml and 1000 ml. So this is how we give. So this is the commonly used. This is called as an accelerated protocol for giving N-acetylcysteine. It's called as an accelerated protocol, because this is, you should be aware of this because it is very common. So there's also an oral protocol, but we prefer usually the accelerated protocol. Most hospitals prefer the same. There are multiple protocols, somewhere 7 to 8, but most commonly applied is this. Okay, so this is one more thing. The other thing that has to be remembered whenever you have a patient who presents with an ALF or enzyme levels in thousands, adult viral toxin. Other thing is what we call as a shock liver. Shock liver, or something called as an ischemic hepatitis. This can be secondary to a congestive cardiac failure, or the patient has diffuse hypoperfusion. This is because of the hypoperfusion that the liver gets. There are 3 uncommon causes, but if you think of that, you will not miss it. One, I already told you, one is acute fulminant Wilson's. One is acute Budd-Chiari syndrome. One is acute biliary obstruction. Acute biliary obstruction, so initially the pressure will cause release of the enzymes, and then later you're going to get an ALP and DGT elevation. So initial part you can have increase in the AST-ALT, and then you can have the subsequent elevation in the ALP and DGT. So these are the things that has to be remembered whenever you are seeing a enzyme levels in thousands. Okay. The other important thing here in ASTs to ALT ratio is it can also help in the prognostication. So let's say there is a patient who had a liver disease. So most of the time liver disease, the ALT will be more than the AST, most of the times, except in like these other conditions. So if the patient who had like this ALT and AST levels now presented like this, it has become a chronic disease and the patient has enzyme levels always like this in the baseline of AST being more than the ALT. Then this indicates that the patient is going into cirrhosis. So this is another importance. Previously known ALT more than AST, chronic liver disease, persistent elevation, now presents with AST more than ALT. Then you think of cirrhosis as the background cause. If it is less than 5 times elevation of normal, it's very, very non-specific and it won't give us any diagnostic clues for anything. So that is the other thing that you have to remember whenever the enzyme levels are in that range. Okay, so that is with respect to the AST and ALT levels. So mostly it is going to indicate a chronic process. Usually it is going to be a chronic process. Or another possibility is a patient had more than 10 times elevation or more than 5 times and now it is resolving. So acute resolving initial insult. So that can also be there. So these are the things we see. So we have seen the hepatocellular pattern of elevation of enzymes. The next thing we look at is cholestasis. So what is important is there can be 2 causes where you can have a cholestasis. So if we take the liver, if you are going to take the liver, and these are the ducts, and then I have the gallbladder joining the cystic duct. It forms the common bile duct. So you can have some obstruction here in the entire biliary tree. Then it joins the second part of the duodenum. The pancreatic duct will join from here and forms the common bile duct. Then ampulla of Vater here, and then you're going to get a biliary tree. So you can have obstruction at any level here. So either it can be an extrahepatic obstruction or it can be inside the bile ductules, inside the liver. So it can be an intrahepatic obstruction. So this is the next point of differentiation. Because whenever you have an extrahepatic obstruction, usually it is because of a mass lesion, extrahepatic. So some cause will be there. Intrahepatic, we have to see the causes. There are so many causes to have extrahepatic obstruction. So that is another thing that we also have to see. Okay, so that's how we'll see. So there are 2 things that you can use. So in the absence, if you just have an LFT and you don't have an imaging, so the first step would be to look at the imaging to see whether it is intrahepatic versus extrahepatic cause. So you look at the right upper quadrant, you look at the ultrasound. That is going to help me differentiate between a extrahepatic versus an intrahepatic obstruction. So if the ducts are dilated, if there is a ductal dilatation, then we think of more of an extrahepatic cause. Whereas in case it is normal, we think mostly of an intrahepatic cause. So in cholestasis, very important is to know that the ALP and GGT is going to be elevated. So coming to some points about ALP and GGT. So ALP is alkaline phosphatase. So it has various isoforms: bone, pancreas, placenta. So these are the things that are going to be there. So how to differentiate these things? So look at corresponding GGT elevation, and you're also going to have from the liver. So if it is going to be from the liver, if it is going to be a liver source, you'll get a corresponding elevation in the GGT as well. So you're going to get increase in the GGT. If there is no elevation in the GGT levels, then mostly it is a extrahepatic source. Most commonly, most of the time, it is going to be in the bone. So if it is the bone, the thing is you are going to have it in the. It's going to indicate an increase in the osteoblastic activity. Only then you are going to have a high bone turnover. This is very important because you have a condition called as multiple myeloma. In multiple myeloma, you are going to have increase in the osteoclast activity. Even though you are getting multiple lytic lesions in the bone, but still the osteoclast activity is high. So you are going to get normal ALP levels. This is one of the things you should look at the LFT. Sometimes you may get a high AG reversal, and the ALP also will be high. So sometimes sepsis can also cause such patterns. So that's why you should look at ALP, so it can give you some clue. Okay, so this is how you are going to use the ALP and the GGT levels. So if this much is clear, so we'll see how do we approach. Because you can have ALP in intrahepatic cholestasis. What are the common things? What are the common causes? So if you have a cholestasis, how do we approach it? So very simple. You can use the right upper quadrant ultrasound to see whether there is a duct dilation. Sometimes you may pick up some mass lesion, something, or there is no ductal dilatation. So if there is a ductal dilatation, then you think of extrahepatic causes. So you should proceed with the ERCP, because that is going to be both diagnostic and therapeutic. If you're going to have a mass lesion, so mostly like HCC or some lesions, then you think of CCT, which is going to be triple phase or triple phase CT, where you look at the arterial phase, portal venous phase, and the venous phase. And if there is no dilatation, so you think of the intrahepatic causes. When you have intrahepatic causes, there are multiple things that come into our mind. So one is you ask the history of drugs, because drugs most commonly can cause this pattern of causing increase in the AST and AL, increase in the ALP GGT levels. So what are the common causes are? One is OCP steroids, which are mainly anabolic steroids. The other commonly implicated drugs are, so I'm telling only the commonly implicated drugs because this is what we are going to use in practice. Apart from allopurinol, you're going to get carbamazepine. So you're going also to get phenytoin. Apart from that, AC inhibitors, especially enalapril, it comes as NVAS as the brand name. So that is one. Then you're also going to have piroxicam. Piroxicam is an NSA, so that can also cause. Apart from that, you can also have azathioprine. Azathioprine is a immunosuppressant drug. It is used very commonly in post-transplant. So in those conditions, you use azathioprine. So if these are ruled out, then you think of autoimmune conditions. Mainly you think of PBC and PSC, primary biliary cholangitis and primary sclerosing cholangitis. Okay. So once this is done, you also think of other causes. So infiltrative disorders. So one is the amyloidosis. One is sarcoidosis. Sarcoidosis, even though there is some liver involvement, we don't start off treatment for it. We don't start steroids for it. The other thing that you have to not miss is viral hepatitis. So sometimes viral hepatitis can present predominantly with a cholestatic pattern, especially EBV and CMV. They can have predominant cholestatic pattern. Apart from that, retroviral disease. So it causes something called as an AIDS cholangiopathy. So this is also one thing that has to be remembered. Apart from that, post-transplant, you can get something called as graft versus host disease. In pregnancy, you can get a intrahepatic cholestasis of pregnancy. So these are the things that you have to think of. Other thing you think of is sepsis. So by far, most common sepsis, drugs, and viral causes. So these are the most common causes that we see commonly. So these are the things that you have whenever you're thinking of cholestasis. So duct dilation, it can be gallstones, it can be a mass, it can be so many things. So that's why you look at the ERCP, plan for stenting. Sometimes if it is very proximal, then we cannot do that one. So then you have to go for a CBD exploration and then remove the gallstones or whatever is the obstruction. Okay. So if this is done, so one more thing here is autoimmune hepatitis. In acute presentation, autoimmune hepatitis can present with just an AST-ALT in thousands. That is also another cause that has to be remembered. So if these are the main ways that we look at left, whether it is hepatitis, whether it is, if it is cholestatic, you see whether there is ductal dilatation. If it is there, then it is mainly extrahepatic. If it is normal, there is no ductal dilatation, then you think of intrahepatic cholestasis. So these are the causes. So what should we do? We should send for a AMA levels. Then you can also look for asthma levels. Then you can also look for AC levels. So that is mainly for the sarcoidosis. So if all this, then you can look for the ANA levels as well. So if this is all coming negative, then you can think of doing a liver biopsy. So these are the things that has to be remembered whenever we are thinking of processing the LFT. So any doubts until this? I'll talk about some parts in the bilirubin handling later. So any doubts until here, or you want me to repeat some particular topic? Can anyone tell where can you get a very low ALP levels? There is one condition where you are going to get very low ALP levels. Can you tell where you get very low ALP levels? Yeah, very good. Someone said Wilson's. Wilson's disease. This is one thing I had not discussed. So importance of low ALP. We always discuss everything high, So what's the importance of low ALP levels? So one is you should think of Wilson's disease. Any other condition? So Wilson's is because of low copper. Then if the patient is having dentures, so they are made of zinc. So that is one more condition where you are going to get low ALP levels. Apart from that, there is one more condition called as hyperphosphatesia. So that will also cause low amount of ALP levels. So these are the causes where you are going to get variation in the ALP. Okay. So sorry, it's not zinc excess, it is zinc deficiency. Apart from zinc deficiency, the dentures, what happens is in dentures it chelates copper. Because of that, you can get some peripheral neuropathy, some Wilson's-like presentation. So the other thing is you can also get it in pernicious anemia. Forgot to write hypophosphatesia. So these are the conditions where you get a low ALP levels. Okay, so this is the way we think of. So I think some of them have joined actually a little late. Okay, so what I'll do is I'll summarize the whole thing and I'll give a simple approach. Okay, with respect to the AST, ALT and how you approach in a simplified way. Okay, because it's always easy to put it as a pattern of injury. So don't try to look for what is the diagnosis, because most of the time these enzymes will not give you a diagnosis. So it is only going to tell me whether it is hepatocellular, cholestatic, or is it going to be a mixture of both, which we call as an infiltrative pattern. Okay, so what do we do? So let's take at the level of the enzymes. So let's say we look at the pattern. This is going to be a summary of what we have. So we have a hepatocellular pattern. We may have a hepatocellular pattern, or we may have a cholestatic pattern. So in the hepatocellular pattern, we know we are going to define it by the enzyme levels more than 3 times in the AST-ALT and ALP-GGT less than 2 times. So once that we have, then we are going to see whether it is going to be acute versus chronic. So you can use the albumin levels. So if the albumin is normal, it's mostly an acute process. If it is low, then it is going to be a chronic process. Okay. So once we know it is there, so you look at normal acute hepatitis and what is the range of the enzymes that are elevated. That will give you a clue. So if we have chronic, so you look at the causes for chronic hepatitis. So when we have chronic hepatitis, so many times what can happen is, so what they say is the first line investigation, what you should send. So whenever you have a first line, what you send is, you look at the enzymes. The initial step is to look for the common causes, toxin, virals. So once that is ruled out, whenever you have a persistent elevation, so one is the thyroid related liver disease, because you can't call it thyroid dysfunction related AST-ALT elevation until unless you have ruled out the other common causes. Apart from that, you should not forget celiac disease. Celiac disease, although not common in our part where we don't see a lot of cases, but very common in places like Rajasthan where they have gluten intolerance. So it may present with just minor elevation in the AST-ALT and it will be persistent. So that is the other thing. And other thing is you can AIH and Wilson's. So these are the things that you should not miss. So the first line, whenever we have an asymptomatic elevation, asymptomatic and it is persistent. So you look at the viral, which is you look for the hepatitis B, hepatitis C serologies. You ask for the history. Most of the time, history, many times some people would have taken complementary alternative medicines or some other drugs. So you see if those drugs are known to cause some hepatocellular injury, or so if that is known to cause, then need not do anything. So you withdraw the drug, give a therapeutic trial and see if it is resolved, very good. So in case it's not, then we think of common things, viral, Hep B, Hep C, HIV. Apart from that, hepatitis A, not very common to cause chronic. It is usually mainly acute. So you will have other prodromal symptoms. But HEV sometimes it can go for a few weeks. Almost like 2-3 months, we have seen slow resolving. Apart from that, not to mention common things that I told you here. Thyroid, celiac, autoimmune disease, Wilson. So you get a serum ceruloplasmin and then ANA levels. If this is the first line. If this is also not revealing anything, think of rare ones. So you think of autoimmune alpha-1 antitrypsin. It's a very, very rare disease. In India, we don't send for hereditary hemochromatosis because it's fairly very rare. You'll just get an iron overload, but you have to do a gene testing. So you look at the transfer in saturation, more than 45%. But you don't usually see this because it's very rare. You have to have some Caucasian race, somewhere, some ancestry, you have to have to call it hereditary hemochromatosis. So India, I wouldn't suggest, but most books give to test for this as well. Apart from alpha-1 antitrypsin deficiency, then the second line is to check for celiac disease. So you can send TTJ levels along with the IgM and IgA levels, along with total serum IgA. Because sometimes if this is low, this also will be low, and you may mistake saying that it is normal. So for alpha-1 antitrypsin deficiency, what investigation you want to send? Baseline to rule out, or to at least pick up. So you look for the protein electrophoresis, SPEP it's called as. So you look at that. Okay, so that much you look for. So once this is done, we see what is the extent of elevation. What is the extent of elevation? And you have your own causes there. More than 15, 5 to 15, less than 5. So again, you can divide it into ALT more than AST or AST more than ALT. So whenever you have AST more than ALT, you have rhabdomyolysis. So you should not forget here, which is rhabdo. Apart from that, all the causes that we mentioned prior, that will fit in. So in this mild hepatitis is where you think of these persistent workups, medications, metabolic disease, chronic liver disease, etc. So once you have seen the extent of the injury, then we look for the cholestasis, whether there is cholestasis or no. So once you know that there is a cholestatic pattern, so you try to differentiate between intrahepatic versus extrahepatic cholestasis, very simple. So this is the summary. So intrahepatic is extrahepatic. You can use the right upper quadrant ultrasound, but also you can use something called as the AST-ALT ratio. So this is what I was telling you, how to use this. So if the AST by ALT ratio is less than 1.5, then it is going to be an extrahepatic cause. But if it is more than 1.5, it indicates an intrahepatic obstruction. So this is one more clue that you can use. So I'm sure you know intrahepatic we have discussed in detail. So then you'll also use the right upper quadrant ultrasound, and then you see whether dilated duct or not. So if it is dilated duct, so ductal dilatation, no ductal dilatation, mass lesion. So then you send for a plan for liver biopsy. If you're not getting any clue, ductal dilatation is there, go for a ERCP. Sometimes here you may also consider an MRCP. Mass lesion, CCT. So this is a simplified approach how you use the enzymes and the common tests in the LFT. Some things that I have not mentioned. One is the bilirubin handling. So I don't want to tell much points because it has been detailedly discussed by Ashra in one of the previous sessions. So we'll not talk about much about bilirubin handling. So this also has to be seen. So whenever you have patient presenting with bilirubin elevation, so we see whether it is going to be conjugated, unconjugated bilirubin predominance, and then we put it in cholestatic versus non-cholestatic. One thing to remember is whenever you have a cholestasis, so we say that there is going to be increase in the direct bilirubin. Okay, but one thing that I want to explain is for this I would require to explain some physiology about the hepatocyte. So many times, if you have been taking care of patient with a CLD, so chronic liver disease patient, so comes with an acute decompensation. Most of the time, what will happen is the total bilirubin will be high and conjugated bilirubin also will be high. ALP levels will be fairly normal. So in this scenario, so should we consider cholestasis or not? So if this is happening, so is it intrahepatic plus extrahepatic cholestasis? Should I work up for an obstructive cause? Because whenever you think very high, so usually it will be like 13 and 10. So total will be 13, direct will be 10. So should you think of working up for extrahepatic cause? So the answer is no. So for this, we have to understand what happens when the body is handling bilirubin. So initially, you are going to get an unconjugated bilirubin that is going to be bound to albumin, that is going to come inside the cell, getting uptake. It gets inside by. So let's assume this is a sinusoid. This is an oversimplification. So this is only to put the points. So what happens? It undergoes conjugation. Once it undergoes conjugation, it gets secreted via the this is the bile duct, bile ductules. Let's say this is because the cell bile ductules. There is one protein here called as this is called as an MRP2 protein, and this bilirubin comes here. So it becomes soluble, water soluble, and this conjugated bilirubin that comes. So there are two things. So it undergoes a circulation, intrahepatic circulation, so where it preserves the bile salts and all. The other thing is going to be excreted, so either in the urine or in the feces. In the feces, it becomes stercobilinogen. This is what gives color to our stools. And urine, it sends urobilinogen that gives a straw color to the urine. So whenever you have an obstructive jaundice, you are going to get pale colored stools and the absence of urinobilinogen in the urine. So what is important is this protein here. So what happens even in advanced stages? So there have been multiple studies that have been done. So even in the advanced liver disease, so what is important is bilirubin. Bilirubin undergoes conjugation, which is a phase 2 process. We have phase 1, phase 2 processes in detoxification. Even with a liver injury or liver damage, the phase 1 is what is predominantly affected, and phase 2 is going to be fairly preserved. So that is one reason. The second thing, what happens is, so because of this, there is going to be increased UGT activation. So UGT levels is going to be preserved. So the conjugating ability is going to be still preserved. The next thing is you look at the MRP2. So what happens is, here there is going to be reduction in the MRP2 levels. This gets downregulated. So because of this, there is conjugated bilirubin that is there in the blood, in the liver. And now what is happening is, it cannot get excreted. So there is a block here. Once that is blocked, so there is increase in the conjugated bilirubin inside the liver. But how is it going to come to the hepatocyte? So this is where there is a process called as, another protein comes into picture called as MRP3. So this MRP3, what it is going to do is, it is going to send some amount of conjugated bilirubin inside the blood. Okay, so there are multiple reasons. There is one mechanism called as bilirubin hopping. So whoever is interested can read further about it. So something called as bilirubin hopping. So whoever is interested can read. But in essence, what happens? There is going to be preserved UGT1A1 activity. That is a summary. This is a summary of the whole thing. There is going to be preserved UGT1A1 activity. The second thing is the MRP2 levels are reduced. So there is conjugate bilirubin inside the liver, and via MRP3, it is going to be produced, sent into the sinusoids, and then it's going to be sent into the hepatic vein, IVC, and in the blood. So this is why even in stages of advanced liver disease, you can still get a conjugated picture. Okay, so that's why you have to look carefully. So many times, because I still remember that mistake I had made. Initially, it was in the second month when I joined post-graduation. Patient was there, CLD. He was not giving any history of alcohol-related, ethanol-related CLD. So just the albumin was low, but enzyme was normal and gradually rising bilirubin. So bilirubin was slowly increasing, and we were not really sure what is happening. So the ALP levels were normal. GGT was coming down. So we didn't know what to do. So initially, I thought maybe it is some obstruction is there. So we did initially right upper quadrant ultrasound. So that didn't show any ductal dilatation or anything. So I thought it should be intrahepatic. Sent for AMA levels. All those, these are all very expensive tests. So then, so this all was not really required. So if I had known the physiology, maybe this all wouldn't have been required and the patient need not have so many extensive investigations. So that is one thing that you should remember. So don't get fooled by this total bilirubin levels. They'll take some time to come down. Okay. So is this clear with whatever we are discussing? I think this is the approach to LFT that I wanted to give. Any other questions that you have? We have finished with approach to LFT. So I'll give one scenario based on like the cases I've seen. So let's say patient, because it is COVID pandemic, COVID-19 illness, which is moderate, started on remdesivir, steroids, which is here we usually prefer a methylprednisolone. We are giving it 40 mg DOD along with your vitamin C and zinc. And now we did, so this is, let's say day 2. So the LFT is like this. Total bilirubin 0.9, direct is 0.3. Then we have the AST is let's say 154. ALT is let's say 100. Then we have the ALP, which is let's say normal. GGT is also normal. Total protein is normal. Albumin is normal. So now what should I do? Patient is already on remdesivir. So what should I do? Should I continue? Should I not continue? Or is this enzyme elevation because of remdesivir, or is it because of something else? So is it just drug-induced hepatitis, or COVID itself is causing all this? So what to do? What do I consider? Okay. So here what is happening? Is everyone able to hear? Yeah, he may be having underlying cirrhosis. Okay, very important. Very important point. So we should know the baseline LFT. Baseline LFT is very important. Many times our Indian patients will not get the reports until and unless patient is previously admitted. That is one. Second thing is history of ethanol intake. Important to ask before admission, after admission, what happened. The other thing is like Dr. Lakshman is saying. So it may be a cirrhosis that the patient is having. But what are the clues that are not fitting cirrhosis is this: the presence of having a normal protein and normal albumin. And whenever you have a portal hypertension or cirrhosis with portal hypertension, usually a patient present like that will have a platelet which is going to be very low. So platelets are also going to be low. Thrombocytopenia is a very strong predictor. Whenever you have normal platelets in patients with CLD with portal hypertension, you should think, is there something else that is increasing the platelet? So because drug-induced hepatitis is a diagnosis of exclusion. So you look for basic, you look for the viral panel. At least the basic ones you look for, because you don't want to miss out on this because the patient may get treated well. So apart from this, then you can consider stopping remdesivir or no. So the indication is, here we can continue remdesivir. So if it is more than 5 times upper limit of normal, you will have to stop. Otherwise, we can continue. Once the remdesivir course is over, what we can do is we repeat the enzymes. If it is coming down, then we need not do anything. So this also will not be really required in the first place because there is a temporal event that is there. So you can give a trial, because first thing that I said, whenever you have elevation, is look for the drugs. So if drug is ruled out, then you think of the viruses. Then other causes, rare ones. Okay, so this is one thing that is, you should remember. I think this much is sufficient whenever you're dealing with a liver function test. We have covered most of it. And this AST by ALT is called as a D-Retis ratio. So it's called as a D-Retis ratio. Okay, so that is one thing that is there. So any questions as of now? Any questions? So I'll give another scenario. This is what, like this today morning I just saw this. So patient is there, presented with chest pain 2 days ago. Now presented with breathlessness and syncope. On arrival, BP was 160. Pulse rate was 30 beats per minute. On JVP, there were irregular Canon A wave. Irregular Canon A waves. This was the history that they had given. So what had happened? This patient, ECG showed interval MI with complete heart block. So this was there. So the patient has undergone a thrombolysis with streptokinase and incidentally detected to have increased creatinine levels and referred. So after this, the patient comes. This is the pattern of LFT. Total bilirubin 1.9, 1.2, direct bilirubin 0.8, AST levels 3286, ALT levels was 2684. Then we also had an ALP mildly elevated at 200, GGT normal, albumin fairly good at 4 grams, total protein 7 grams. So what do you think is happening in this patient? The other thing, significant ones which are is troponin was more than 50,000. This is the history. He came with severe acidosis also. The patient had pH of like 7.1, bicarb was 4, potassium was initially more than 7. So this is the history of this patient. So what do you think is the diagnosis now? Yeah, very good. Someone has given the answer. Congestive hepatitis. Yeah, correct. It's congestive hepatitis. So this patient is okay. He had all cardiac history. So usually we think, so whenever it is more than thousands, so and in this scenario, we think of ischemic hepatitis. The best part was, there came another twist. The patient was newly detected retroviral positive. So should we start drug or should we not start drug? So that again becomes a huge question. The CD4 count was okay. So we are just waiting for his AST levels to come down because we don't want to increase the hepatocellular injury again further. So that is one thing. So if the same scenario, now patient has come and I'm not really sure whether it is ischemic. So sometimes full-blown sepsis patient can also come like this. Suddenly he presents with acute liver failure, viral sepsis. So let's say we'll take the same thing. So another scenario, patient presents with fever, malaise, bleeding from gums. In 3 days, attenders have noticed that the patient is having reduced responsiveness since Monday. And also they have noticed yellowish discoloration since Monday. So these started about 7 days back. Now we'll take the same. So baseline, we'll see the LFT. Mainly our approach is to look at the LFTs. So here, let's say it is 3146. And AST is somewhere 2449 or 46. Total protein normal, albumin normal. ALP 230, GGT 180. So what is this now? Or what test you want further? What testing we should do? Yeah, correct. That is ischemic hepatopathy. So what test we should do further now? And here you didn't ask me the bilirubin. So the bilirubin here is, let's say 8. Total bilirubin, direct bilirubin is 4.6. Yeah, so you should look for viral serology. So the first step is to look at the viral serology. So because there is short history, fever, malaise, so the patient is going into. So next thing you should also look at the INR. So that is why it's very important. So here, let's say it is 4.5 INR. So the patient has encephalopathy, he also has coagulopathy. So he's going into an ALF. And he also has jaundice. So this is ALF. ALF and the patient going into ALF because of hepatitis A is less likely. Usually it will be something else. So hepatitis A, you send. Hepatitis A is little expensive. Usually we look commonly for hepatitis B, Hep C, because sometimes they may present with acute flares like this. Other thing is Hep PV, especially in pregnancy. The other thing is sometimes when you have B plus D co-infection or super infection, so that can also present like this. So these are the common things that you think of. Then you think of the other things. Okay, what I wanted to tell was one more important thing that was there. This patient, let's say he had a BP low. BP was, let's say, only 90/60. Pulse was 104 and it was regular. So now what to consider? Again, is it ischemic hepatitis? Is it viral hepatitis? Now what to do? Yeah, very good. So the INR I've told you 4.5. So now what to do? Whenever you're thinking like this, if it can be because of a cardiac cause, it can be because of sepsis. So what you can do is you can look at the echo. Bedside, you can do an ultrasound. You look at the filling pressure. So mainly you look at the IVC. You can also look at the echo texture and that's the bedside ultrasound. Sometimes by chance you have sent LDH levels because usually when you have elevated bilirubin, sometimes we send for LDH to differentiate hemolysis versus non-hemolysis. So if there is LDH elevation, so if it is because of the RBC death and death of the cardiac tissue, then the LDH is going to be very, very high. So LDH will be disproportionately more than the ALT. So you can use this ratio called as ALT by LDH ratio. So ALT by LDH ratio will be less than 1.5 whenever it is ischemic. Probably ischemic origin, you can use this. Okay, so this is another use that is there. So this is another scenario that is there. Okay. Should we stop here or should we continue? I think I'm done with the LFT. So any particular questions in liver function test you want to ask or you want to add some point? I've covered most of how to approach LFT. So any particular thing you want to add or you want to ask? So it's very, very important to take drug history. Many times drug-induced hepatitis, we won't know what to do. We'll keep thinking, especially ATT and all. Another thing is amiodarone. Amiodarone can also cause all these things. So any questions or we will stop at this point? Okay, one interesting fact now. So I think we'll finish with this use of discriminant factor. Okay, I'll discuss alcoholic hepatitis because someone will ask use of discriminant factor. So I'll discuss alcoholic hepatitis because there are many small subtle changes that are there. This not yet come inside the guidelines. So alcoholic hepatitis. Someone has mentioned, so we'll discuss this. Okay, so we look at alcoholic hepatitis as it can involve multi-systems. So it's a multi-system involvement. Okay, it's not always has to be acute. It can be acute or subacute after the initial insult, consumption of significant amount of ethanol. Okay, usually it is going to be massive amounts of ethanol consumption. So usually initially if the liver is good, it undergoes inflammation. So it undergoes hepatitis. And then it ends up in a irreversible stage, which is cirrhosis. Okay, so it will go into two phases. One is the compensated cirrhosis, one is the decompensated cirrhosis. Anyway, so in alcoholic hepatitis, you can have cerebral edema, you can have patient coming like sepsis, you can have INR derangement, you can have mildly low albumin levels, so all those things. So the most important I said was the AST is to ALT ratio more than 2:1. It is found that if it is more than 3:1, it is very, very predictive of alcoholic hepatitis. The other than that, the importance is the AST and the ALT levels. It will be less than 500 and less than 300 for the reasons that I have discussed before. So once you make a diagnosis of alcoholic hepatitis, and usually the bilirubin levels somewhere around 8 to 10, usually this is the range it comes. Okay, so these are the bilirubin levels. Okay, so once you have made a diagnosis of alcoholic hepatitis, So you have to see whether there is going to be increase in the inflammation. So to reduce the inflammation, we give steroids. Okay. So whether to give steroids or no, how to decide is using the discriminant factor. So when you have the discriminant factor, so anyone knows what is discriminant factor? It's called as matrix discriminant factor. Answers. So to look at the discriminant factor, we take so we are going to mainly look at the INR or the prothrombin time. So we take 4.6 into the PT of the patient minus the PT of the control, the prothrombin time, and you add it with the total bilirubin. Okay. So this is what is called as a matrix discriminant. If it is more than 32, we say the patient is going to respond to steroids. We have to give steroids. So there are some modifications that are there. So you can divide them into a low risk and a high risk. So whenever that is based on the discriminant fraction, matrix discriminant, which is less than 32, the matrix discriminant fraction is more than 32, they are high risk. So they will go bad very soon. Okay. So then what we essentially look for is if we have the NLR. So usually we'll have the NLR also. Okay. So the NLR, neutrophil lymphocyte ratio, because we have to look whether the patient is going to be responsive to steroids. So in this patient is only going to be conservative. Okay. Here what we do is we can give two things. Either you give corticosteroids. So usually you give prednisone. Another thing you can give is pentoxifillin. So when to give pentoxifillin and when to give steroids is another question. And how long to give? That is another question we'll have. So whenever you have steroids, so you give it somewhere at 40 mg per day. This is the dose that is recommended. But you should be careful when not to give steroids, because patient will die if you give unnecessarily and non-judiciously. So whenever there is an active sepsis, you don't give. Whenever there is an acute upper GI bleed, you don't give. Whenever there is a renal dysfunction, so we don't prefer giving a steroid. So in those conditions, you can give pentoxifillin. So it's given at 400 mg TID. One name we use is called as Trental. They were given about 2 to 3-4 times we have used. So once you have given the steroids, you have to look for the response to steroids. Look for a response to steroids. So that is using the Lilly score. If the score indicates there is no response or poor response, stop. The patient will not benefit. So there are some increasing evidences of whether the patient will respond to steroid at baseline itself. When the patient is admitted itself, will the patient respond or not? We can use by using the NLR. Okay, so this is called as a neutrophil lymphocyte ratio, which is very, very common in COVID. Yeah, this was called as a STOPA trial. Correct. It's called as a STOPA trial. So that was for whether to give steroids or not. So there was another trial, and I don't remember the name. They divided patients into whether they gave both steroids with pentoxifillin and plain, and whether they benefited or not, and they didn't find any great benefit. Okay. Another modification is there. I'll just come to it. So this is an NLR. So whenever the NLR is somewhere at 5 to 8, the NLR is between 5 to 8, then the patient mortality reduced. But if the patient is less than 5 or more than 8, the NLR, then they didn't have good outcomes, poor outcomes. Or we can put it as poor outcomes. So there are multiple things also. So this is one thing. Other thing is there is increasing use of STOPA trial. Yeah, STOPA trial is a trial that there was done. It said steroids can be given in patients with high risk alcoholic hepatitis. Okay, so that is a STOPA trial. Yeah, so this is poor outcomes. Okay, so then one more thing is Lilly score at day 5. So some of the people have used this as well. So this is also being used. Based on this also they are titrating. So apart from this, so what else you give is apart from steroids? So there is another trial, they said we'll combine both because there is N-acetylcysteine that is there. So that acts as a scavenging agent. So you give N-acetylcysteine. They said you give N-acetylcysteine also. So although most of the times when you see, you will be giving this combination. You won't give only steroids. Not very great significant benefit. But if you see the trial, there's concluded saying that there is no great benefit. But if you see the subgroup analysis, patients who had given NAC, okay, so they had little better outcomes. So subset of them, they had better outcomes compared to those that were given only plain steroids. So this is one thing about alcoholic hepatitis. So someone said Madrish discriminant. So I just told about alcoholic hepatitis. So they're trying, I think, future they may include many other parameters. There is also increasing role for whom to consider in patients who have alcoholic hepatitis. Some patients are very sick, so they have very worst outcomes. So in them, whom to consider for a liver transplant? So that is also a question. There's no head-to-head comparison. We don't have definite answers, but some studies are still ongoing in that. Okay, yeah. Cool. Any questions? Or we'll stop here. Yeah, I think we can call it a day. Okay, yeah. So this is a simplified way how you interpret LFT. Okay, so this is some details about. So we've gone it a little in detail. So what I'll try to do is I'll try to give a summary. I'll try to make a short summary video on how to interpret LFT. At the end, maybe in another 1 or 2 days, I'll make that so that it will be easy. Because 1 hour videos, sometimes some people feel it difficult to watch. So we'll try to make that as well, 15-20 minutes video. Okay? Yeah. So if there are no questions, we'll end it. Okay. Yeah. Was it clear? Like the audio, the technical issues, all are fine, no? Yeah, cool. So we'll meet maybe, I don't know how, next week maybe we'll see some class. So I'll take on thyroid because thyroid is also very common. So we'll do same like this. We'll approach it in this way only. So when to use thyroid, what diagnostics to use, and what are the other things. So how you can use the ultrasound of the thyroid and all we'll see. Okay, fine. We'll meet.